if your doctor has recommended surgery for your sciatica, or if you are sitting on a waiting list for a spinal procedure right now, I want you to do one thing before you make that decision. Watch this video completely, not because surgery is never the right answer, because sometimes it absolutely is, and I will tell you exactly when, but because surgery for sciatica should always be the last resort, not the third option, not the recommendation that comes after 2 failed injections. The absolute last resort arrived at only after every appropriate conservative treatment has been genuinely and completely exhausted, after the specific clinical criteria that actually justify surgical intervention have been clearly identified and confirmed, and after a fully transparent, honest conversation about realistic outcomes and genuine risks has taken place. And here is the truth that I have seen repeated too many times in 22 years of treating spine and nerve conditions. Too many patients are going into surgery without that conversation. They are sitting in a consultation room in pain and desperate for relief. And in a 15-minute appointment, they are being moved toward the most consequential health decision of their life without being given the complete picture that they deserve to have. I am Dr. Michael Kent, and today I'm giving you that complete picture. What the research actually shows about sciatica surgery outcomes, what your surgeon may not have told you, the real risks that deserve to be on the table before any decision is made, and the precise, specific clinical situations where surgery is genuinely the right and necessary choice and should not be delayed. This is the conversation that should happen before every sciatica surgery recommendation. And it starts right now. Before I get into everything, I need you to do one thing right now. Scroll down to the comments section and drop your age and your city, just those 2 things. And tell me one more thing. Have you been told you need surgery for your sciatica, or are you currently considering it? Drop it in the comments right now. I personally read every single comment on this channel, and I want to know exactly who is watching this video today. Age, city, and whether surgery has been recommended to you. Drop it before you forget. Now let me start with the most important piece of context for everything I'm going to share today. I want to be absolutely clear from the beginning. I am not anti-surgery. I am not here to tell you that spinal surgery is never appropriate or that surgeons are making recommendations in bad faith. That is not true, and it would not be a responsible or honest thing to say. Spinal surgery has genuinely changed lives. It has restored function, eliminated pain, and given people back their mobility in cases where it was the right and necessary intervention. There are specific clinical situations where surgery is not just appropriate, it is urgent and essential and should not be delayed. I will describe those situations clearly and specifically later in this video. What I am here to do today is give you the complete, balanced, evidence-based picture that allows you to participate fully and intelligently in the most important decision you may ever make about your physical health. Because an informed patient makes better decisions, and better decisions lead to better outcomes. That is the only agenda in this video. So let us start with what the research actually shows. And I want to walk you through this carefully because the data is more nuanced than either surgical advocates or surgical critics typically present it to be. The most commonly performed surgical procedure for sciatica related to disc herniation is called a discectomy, a procedure in which the portion of the herniated disc that is pressing on the nerve root is surgically removed to decompress the nerve. For patients with severe, confirmed disc herniation causing significant nerve compression, discectomy has good evidence behind it for producing faster short-term pain relief compared to conservative treatment. In the short term, meaning the first 6 to 12 weeks, surgical patients often experience more rapid improvement in their leg pain than patients who pursue conservative management. And for someone who is in severe debilitating pain, faster relief is genuinely meaningful and genuinely valuable. I want to acknowledge that clearly. However, and this is the part that deserves equal time and equal weight in every pre-surgical consultation. When you look at the research at the 1-year mark and beyond, the picture changes significantly. Multiple large, well-designed studies have found that at 1 year following treatment, the outcomes for appropriately selected patients who had discectomy surgery and patients who received high-quality conservative care are not significantly different in terms of pain levels, functional ability, and quality of life measures. The surgery produced faster initial relief, but by 1 year, the conservative treatment patients had largely caught up. This does not mean surgery is wrong for every patient. It means that for many patients, particularly those with disc-related sciatica who do not have the urgent clinical indicators I will describe shortly, The choice between surgery and comprehensive conservative treatment is not a choice between a good option and a bad option. It is a choice between faster short-term relief and a longer but equally effective natural recovery. And that is a conversation that every patient deserves to have before they consent to a surgical procedure. Now, let me talk about something that almost never comes up proactively in the surgical consultation, and that I believe ethically must be part of every honest pre-surgical discussion. It is called failed back surgery syndrome. This is a clinical term for a condition that develops when spinal surgery does not achieve the intended outcome, and the patient is left not just without the relief they were expecting, but often with persistent or worsened pain, new neurological symptoms, scar tissue around the nerve that creates ongoing irritation, and significantly fewer remaining treatment options than they had before the operation. Failed back surgery syndrome is not rare. It is a documented, recognized, and unfortunately common outcome of spinal surgery, affecting a meaningful percentage of patients who undergo these procedures. The causes are multiple. Sometimes the wrong level was operated on. Sometimes scar tissue forms around the decompressed nerve root and creates new compression. Sometimes the underlying conditions driving the sciatica, the chronic inflammation, the nutritional deficiencies, the lifestyle factors, were never addressed and continue to drive symptoms even after the structural problem was corrected. And sometimes the structural finding on the MRI that prompted the surgery was not actually the primary source of the pain to begin with. The imaging found something. The surgery fixed that something, and the pain remained because the something that was fixed was not the real problem. I want to also address the issue of surgical risk in a straightforward and factual way, not to frighten you, but because informed consent requires that you understand what you are agreeing to. Spinal surgery carries the same general risks as any surgical procedure: infection, adverse reaction to anesthesia, blood clots, and bleeding. But it also carries spinal-specific risks that include nerve damage during the procedure, cerebrospinal fluid leak from incidental durotomy, adjacent segment disease where the vertebrae above and below the operated level deteriorate more rapidly because of altered spinal mechanics, and the possibility of the disc re-herniating at the same level requiring a second procedure. None of these risks are reasons to automatically refuse surgery when surgery is genuinely indicated, but all of them are reasons to pursue surgery only when the clinical case for it is clear, strong, and supported by exhausted conservative alternatives. So when is surgery genuinely the right choice? When are the clinical criteria met? Let me be very specific and very clear about this, because this is the information that is most important for protecting you from both undertreatment and overtreatment. Surgery for sciatica is urgent and should not be delayed when you experience loss of bladder or bowel control. This indicates a condition called cauda equina syndrome, which is a genuine spinal emergency requiring immediate surgical intervention. Surgery is also urgently indicated when you develop rapidly progressive neurological weakness in your leg, meaning your leg is becoming measurably weaker week by week in a way that threatens your long-term function and mobility. These are situations where the conversation about conservative treatment versus surgery is not relevant. You need surgery, you need it promptly, and you should pursue it without hesitation. Surgery becomes a strongly reasonable and well-supported option when you have severe confirmed disc herniation with clear nerve root compression on imaging that correlates precisely with your clinical symptoms, when your pain is severe enough to be genuinely disabling and significantly impacting your quality of life, and when you have completed a genuine comprehensive course of conservative treatment, typically a minimum of 6 to 12 weeks of high-quality physical therapy, appropriate pain management, and lifestyle modification, without achieving adequate relief. In this situation, surgery offers the genuine benefit of faster relief, and the research supports it as a reasonable choice when the conservative window has been genuinely exhausted. Surgery is premature and should be reconsidered when it is being recommended after only 1 or 2 failed injections without a comprehensive conservative trial, when the imaging finding does not clearly and specifically correspond to your symptoms, when you have not yet addressed the underlying inflammatory and nutritional factors that may be driving your nerve pain independently of the structural finding, or when the recommendation is coming primarily from the severity of your pain rather than from clear objective clinical and imaging criteria. Pain alone, even severe pain, is not by itself a surgical indication for sciatica in the absence of the specific criteria I just described. Pain is a reason to pursue treatment aggressively. It is not automatically a reason to pursue surgical treatment specifically. Now, I want to tell you about a patient named Thomas. He is 62 years old, a former electrician from Michigan who came to see me after receiving a surgical recommendation for left-sided sciatica that had been present for 8 months. Thomas had significant leg pain. He rated it consistently at 7 or 8 out of 10, and his MRI showed a disc herniation at the L4-L5 level with moderate nerve root compression. His surgeon had reviewed the imaging, noted the severity of his symptoms, and recommended discectomy surgery. Thomas was frightened but willing. He was in enough pain that surgery felt like the only way out. Before proceeding, he came to see me for a second opinion at the recommendation of his family physician. When I evaluated Thomas, I found several things that gave me reason to pause. He had not completed a comprehensive conservative treatment program. He had received 2 epidural steroid injections, both of which had given him 4 to 6 weeks of meaningful relief before wearing off, but he had not completed a structured physical therapy program, had not addressed his significantly elevated inflammatory markers, had not corrected his vitamin D3 deficiency that showed up in his blood work, and had not implemented the lifestyle modifications that the research supports as first-line treatment for his presentation. He was also a stomach sleeper, something nobody had asked him about. His disc herniation was real, his nerve compression was real, his pain was real and severe, but the full conservative treatment picture had not been tried. I recommended a 12-week comprehensive conservative protocol before reconsidering the surgical option. Thomas agreed. At the 12-week mark, his pain had reduced from a 7 or 8 out of 10 to a 2 or 3. He was sleeping through the night. He was walking 2 miles every morning. He was back to most of his normal daily activities. He chose not to proceed with surgery. At the 6-month follow-up, his MRI showed the disc herniation had reduced in size, a natural process that occurs in the majority of disc herniations given enough time and the right biological environment. He told me at that appointment, "Dr. Kent, I was 48 hours away from booking that surgery. I cannot imagine what my life would look like right now if I had not come to see you first." I share Thomas's story not to suggest that his surgeon was wrong to raise surgery as an option. With his imaging and his symptom severity, it was a reasonable clinical consideration. I share it because Thomas had not yet exhausted the conservative options that the research shows are equally effective at 1 year. And once he did, surgery became unnecessary. Here are the 6 questions I want you to bring to any surgical consultation you have for sciatica. Write these down, ask them directly, and listen carefully to the answers. First, what specific clinical criteria, in my case, make surgery the recommended option at this time? Second, what does the research show about outcomes for patients with my specific presentation at the 1-year mark comparing surgery to comprehensive conservative treatment? Third, have I genuinely exhausted all appropriate conservative treatment options, and if not, what remains to be tried? Fourth, what are the realistic risks of this specific procedure, including the possibility of failed back surgery syndrome? Fifth, what is your personal experience with this procedure? What is your complication rate, and what outcomes have your patients experienced? Sixth, what happens if I choose to pursue an additional 12 weeks of conservative treatment before making a final decision? A surgeon who is recommending surgery in your genuine best interest will answer all 6 of these questions openly, completely, and without defensiveness. The answers you receive will tell you a great deal about whether you are in the right hands and whether the timing of the recommendation is appropriate for your specific situation. Your spine is not something to approach hastily. Your nerve is not something to operate on before the full conservative picture has been genuinely explored. Surgery has its place, a real, important, sometimes urgent place, in the treatment of sciatica. But that place is last, not third. It is the door you walk through when every other door has genuinely been tried and has genuinely not been enough. Thomas's story is a reminder of what becomes possible when you give the conservative doors a real and complete chance first. Right now, before this video ends, scroll down to the comments and leave your age and your city. Then tell me, have you been told you need surgery for your sciatica? How long have you been dealing with this pain, and what treatments have you tried so far? I read every single comment personally. I respond to as many as I possibly can. And if you are facing a surgical decision right now, please get a second opinion before you proceed. You owe yourself that conversation. I am Dr. Michael Kent, and I will see you in the next video.